want to thank Dr. Julien, for inviting me here. It's not often that I get a chance to speak in a crowd where I don't have to justify my approach of social pediatrics. We're all here because we understand that concept and want to do better at it. So it really makes my case a lot easier because I could move then on to content and ideas. As a pediatrician, I often see mothers, and I've worked in inner city Boston my whole career, after they have a baby. And one of the things I learned is the low-income mothers that I see there have the same aspirations that I have for my babies and my colleagues had for their babies. And really what that has led to in my own mind is that we need to help those parents to support them to meet the aspirations they have for their child. It's easier for some of us because of our ability to purchase things, our education and other things. What happens for a low-income parent, there becomes a lot of barriers that put in their way. And basically the key of my work for 40 years is under the heading of that the best way to help children is to help their parents, but the best way to reach parents is through their children. And from that, I've developed some ideas, again, to help parents reach their aspirations for their children. And to start out, I want to show you a video from my colleagues, Dr. Brazelton and Tronick, that illustrates the cornerstone of my starting point for efforts to help children and parents. Can we see this video? It's called The Still Face. Many of you have probably seen it. I want you to notice, first of all, this unremarkable, wonderful interaction. But what's happening is the mothers and babies are taking turns. So the baby at 3 months of age already knows that when his mother says something, he stops, and when she finishes, he goes. She's not doing the same thing. This is not only early learning, but it's the basis of the affective communication and the basis of a relationship. I'm going to use this video as an illustration of, again, the cornerstone of my thinking. You can play that now. But watch this interaction. So the mother's told to turn away and then turn back but not respond to her child. And this will be a little difficult for you to watch. I want you, again, 3 months of age, the baby has an expectation if he smiles or looks at his mother, she smiles back. That expectation is being violated. And let's see what his response is. So this is both emotional development and cognitive development. And you're going to see the baby try a number of strategies already at 3 months of age to get his mother's attention, different strategies. The distress, unlike the happy interaction, is depicted by the baby's negative vocalizations, the jittery motor movements now. You saw him before play with, little self-stimulation. It's not that the baby's bored. Yawns are sign of stress, and you'll see a cough later on. The mother is then told to turn back, and then this is what we call the repair, and I want to mention that. She'll use her tone of her voice, her facial expressions, her body movement to reconnect emotionally with her baby. That can be painful to watch, but while this was a research paradigm, we're actually now using this clinically. We're now using this clinically with parents to elicit from them these things that happen at home, which are just, in some ways very common. The repair, by the way, is that anytime there's a disconnect like that, whether it's 3 months or 3 years, an emotional reconnection, either physically by hugging or kissing, by using words, saying, I'm sorry, mommy was tired, yelled at you. Those things become important because there's always times when a parent's going to get their attention divided. But I use this because all the things that we're talking about in the social context of a parent's and family's life can interfere with that interaction and can disrupt that. And I believe that the relationship is important for the child's trajectory of growth and learning and health. And these violations that you can see if it happens too often and chronically is a kind of trajectory that we see, that we worry about, that we're here to prevent. So this is the core, early on what goes on. Going back, my comments are, you're supposed to, with a TED Talk, take one idea. Well, my one idea is the importance of new ideas and innovation. And it's not to prove anything, it's to start a different process. And then there's learning that can go on. So in my past, the new ideas that I've had, and some of you know them, many of our practice in certainly the US and Canada, is Reach Out and Read, where we gave books to parents at every pediatric visit, which promoted not just literacy, but the kind of interaction that can only come from reading, the kind of shared affective response, shared vocal response, which is really critical. And I did that because when I asked parents in my clinic whether they were reading to their children, because I had young children then and knew it was important, we did something called Health Leads, where we had college volunteers connect parents to community resources. Working besides with the doctor, we developed something called Healthy Steps, which use a child development specialist as part of pediatric care, very similar to what you do here with the social worker. It's all the same. How do we build a team that can meet the multiple needs of families, both with their expertise and time? I'm going to emphasize one of these a little more, an idea, is that I see parents a lot of times, a child with asthma and the housing conditions are poor, or parents denied benefits that they were supposed to get, special education that they were supposed to get and didn't happen. Frequently I would make a call. Sometimes I was successful, many times not. And my nice telephone call turned into my frustration and sometimes yelling at landlords, which, as one would know, didn't do any good. I was talking to a friend of mine who's a lawyer, explaining my frustration about this situation, and he said to me, "What does the law say?" I said, "I don't know, and I didn't understand why that mattered." He repeated it, "What does the law say?" And again, I said, "I don't know." So he looked up some things for me, went to law books, and I read some of these laws and regulations, and I was absolutely shocked how thoughtful and well-written they were. And then I realized the problem was the disconnect with people's lives and these laws that were written to protect families, by and large, from falling through the cracks. So the other idea was we put a lawyer in a pediatric setting. It's called a medical legal partnership. And over time, we worked out the relationship between lawyers and social workers and doctors. It's a little tricky because the culture of legal practice is different than medical practice, and we bridge that like you would if you go to another country to learn the culture, is not stare outside the window and see what's happened, you go down. So I had the lawyers would shadow the doctors, for at least a week. They would develop relationships with those doctors. They could see what's going on in the office, and through that relationship, the doctors over time learned questions to ask, could do some more triage themselves. The social workers over time learned skills from the lawyers so they could handle more, and the fact that they had lawyers backup was important, let alone for what the lawyers could do. The other thing I learned is lawyers are like our intensive care doctors. They like the action, when there's really something going on. Well, social pediatrics is about prevention, and the lawyers that work with us have to, sort of align ourselves with prevention. So we want to see that these social problems, some of which are legal problems, so when we can identify them as legal problems, they're legal answers. It's not exciting, but it's in the spirit of for the spirit of the law to protect and prevent problems and to protect the family. And this has been a real canon to pediatric care from, dealing with some of the social problems. There are many where the laws aren't there. It differs in the US and Canada and other places, but where you have laws that are made to protect families and protect the health, and also benefits, then you want to make sure that they're being delivered. And what the key is not to go beyond legal aid in a health setting, but to think about population health. So the best example came out of a report and a study written from Cincinnati, where the lawyers, after seeing one child with asthma, looked up who owned the building, and it was a big apartment building, and because they wanted to, because the conditions were terrible. And then a few weeks later, a child from a different address, different apartment building, they looked up again the owners, and lo and behold, it was the same owners, a corporation from New York. And then they looked at all the buildings that these owners owned. They were all in decrepit situations. So they started working on the kids with asthma. In the buildings where there were no children, they organized the tenants. In a year and a half, those owners sold, and they had to get out. So that's the kind of population health that lawyers can do, and that's just about housing conditions. But the lawyers helped us write formatted letters to prevent utility shutoffs in the wintertime, and we all learned to do things. Most of our letters to advocates for parents were like discharge summaries. Doctors don't know how to write them. Lawyers taught us to write, this is a child, this is his problem, he has asthma, the law says this, and you're in violation of it. It's really that specific and not the page and a half of the medical history. So we've all learned a lot, and it's been a healthy relationship. I know there are medical legal partnerships here. I know there's some in Vancouver and in Toronto, and I think it's an idea. I want to quickly mention some new ideas, because these ideas go back the last 20 years and have had a chance to evolve and grow. And I realize how when you have an idea to solve one problem, the nice thing is sometimes it solves other problems, that there are ripple effects. So here are some of my newer thoughts, at least for social pediatrics. And that's a two-generation model of pediatrics, going back to helping parents. Not that the pediatrician is going to take care of the health problems of parents, although family physicians can, but there are a number of parental mental health problems and health behaviors that the pediatrician needs to be trained in, and that's maternal depression, domestic violence and trauma, it's cigarette smoking, it's drug and alcohol use. Our job, either through validated screening questions or just conversation in the context of a trusting relationship, should be able to identify these problems. There are effective treatments for all of them. And that's the key, again, realizing we may be the only physician that a parent will come in contact. In each of these cases, these things are not only harmful to the parent, but they're harmful to the child and their effective treatments. I think for us to increase value to children, we have to take some role with parents. One of the things that I'm particularly advocating, because some people do some of those things, is I think social pediatrics have to help mothers with preventing unplanned pregnancy. We now have long-acting reversible contraceptives. They're called LARCs. They're 99.5% effective, and they're safe. And while women may not be able to control, because of males, their sexual activity, they should be able to control their reproductive activity. And not only is it helpful to the health of parents and children to prevent unplanned pregnancy, not only does it decrease healthcare costs, it really potentially attenuates the link between too many children and poverty and becoming overwhelmed as a parent. And the role for the pediatrician, I think, is at the 2-week or 2-month visit, whenever, what's your plans for your next child? I assure you, from the parents I talk to, most of them say, not for a while. And then our job is, because parents actually trust us, is to just talk about it. Some people may want to get trained to do the implantables themselves. IUDs are a little more tricky, but can move ahead with preventing unplanned pregnancy. And I think the key is it's close to 100% effective. Anything that's effective should be on our highest priority to deliver. Obesity is a problem, but none of the counseling we do is effective. So as we think about what we do, the highest priorities, like immunizations, should go towards effectiveness. Lastly, I want to talk about a parenting strategy that's called Parenting Journey. It's something that I became aware of recently, and I think it's the missing link in all of my work. Parenting Journey is 12 sessions. There's about 150 sites in the US. They're all structured activities each session, and the parents really have to participate. It can be run by someone in the community, not necessarily professional, although professionals can. And when I say professionals, whether it's social workers or physicians or psychologists, it doesn't really matter. But what I like about it, the first 3 sessions start out for parents to revisit their childhood. Because you can give parents behavior management strategies and all kinds of things to deal with current events, but all of this emanates from their childhood, the models they had as parents, how they were treated as children, and that's the beginning of change. And after they can get in touch with that, and one strategy after the 3rd visit is to write a letter to your parents, whether they're alive or not, whether you mail it or not is not the point, but to say whatever it is you would like to say, the good, the bad, all bad, or a mixture, and then read it to the group. These are very, very powerful, but that then sets the stage for what are the changes that you want to start making in your life, informed by what happened in your childhood. You know, because many times parents are doing the same things to their children that they really dislike that their parents did to them. And one of the key things that I learned is the power of the group. As a physician, I've always dealt one-to-one. I've had good training. I can elicit these things. But the group of women not only supported each other, but really were sources of strength for the other women that allowed them to both deal with the past and also support them for changing for the future. So these are the few ideas that, whether they work or not, how they work in a setting, you know, the notion of preventing unplanned pregnancy, of doing something like Parenting Journey, which is different than behavior management. And lastly, and I'm mentioning all these things because these are just opportunities I can talk with people, is to use some videos for promoting child development in the visit to change the discussion. Videos like the still face, which we're using, that can get parents to start asking questions and talking about things that otherwise they haven't talked about. So my time is up, and I want to thank you all very much. And again, the idea was to share these ideas with you to start discussions and to start ideas, whether it's with me or myself. The one key about the things that I've done is they're not rocket science. They're very simple, and the challenge is implementing them on the ground, but that just takes some passion and some commitment, and it can be done. Thank you.